feet on the short hill. Set up on the first one, just across and went around, came back, went up, went around, came back.
All right, you guys, we're going to go ahead and get started. This is kind of fun to be all together again. So we're really lucky we have station 101 and 104 here live with us, and then for those of you on WebEx joining with us, thank you for joining. Just a few things. As you are joining on the WebEx, all the lines are muted. So if you need to make a comment, you can either put it in chat or press *6 to unmute. We just ask that you please mute yourself right after, and that'll just help us so we can keep the sound okay. And then you can also chat in the WebEx forum your full name, agency, or station, so we can give you credit for this and put you on our attendance roll, or you can text directly to me, which is Holly at 801-755-3317. And that phone number is also listed in the chat, so whichever more convenient for you. We're really lucky today to have our trauma team here. But to start things out, we have Jeremy Bradshaw, who is our new CEO. We're going to turn some time over to him to just kind of introduce himself and give you some updates. And then we're going to turn the time over to our trauma team. We have Dr. Mitchell, who's our trauma medical director. We have Cardi Cervantes, and she is our trauma program manager. We have Nikki Wall, who is our PI, our performance improvement part of the team, and then we have Brittany Clark, who's in charge of our outreach and education. So from that, we'll start with Jeremy, and then we'll lead on to trauma.
Thanks, Holly. Welcome to St. Mark's. We're excited to have you here and appreciate you being here. As Holly said, I'm fairly new. I've been here about, 4 months at St. Mark's, and excited to be here. I come here from Vegas, where I was the CEO of a hospital there. But my family and I are originally from Utah, and so we're excited to be back in Utah. We're from Beaver, Utah. If anybody knows where Beaver is, that's where I call home originally. So we're excited to have my kids and I back in the great state of Utah. You know, as we look at St. Mark's last year, despite the pandemic, we still had a lot of great things happen. And a lot of that was because of you. And when we look at our key service lines and some of the growth that we saw, again, we come back to you all and our relationships with you. And so we thank you for that. Because of you, we were able to grow in some of our key service lines still, despite being in the middle of a pandemic. With that, we also saw some great things happen on the quality front. And I don't know if you know, but within HCA, which is about 190 hospitals, St. Mark's ranks usually consistently in the top 20 from a quality standpoint. And so that compares us nationally to the hospitals across the country. And so we're proud of the quality work that's being done here. And as we look forward to this year, to 2021 and beyond, we want to build upon that and make sure that we are really driving our quality agenda. We're also very focused on growing our key service lines, trauma being one of them. And obviously, you're going to hear from our trauma leaders here shortly. But we believe there's a lot of opportunity there to grow. And on that growth front, also, you've noticed, I'm sure, and I'm sure you're dealing with the construction that is going on. We apologize for that, but we are excited for the tower project that is officially kicked off. Kicked off just a few weeks ago. That's a little over a 2-year project to build that new tower, and so we're very excited about what that will do for us. It adds not a lot of beds in terms of incremental beds for us, about 15 or 20 incremental beds. But what it will do for us is allow us, once we have the tower done, to go back through the existing tower and renovate those rooms. And if you've seen our patient rooms, probably some of the smallest, certainly that I've seen, and so that will allow us to go back through. And basically what we'll be doing is taking 2 rooms and converting those to 1 for our patients. And so we're excited about the opportunities there to really meet better needs of our patients in the community. And so as we look at this year, we really are excited about what we have going on the growth front. And again, I would just say a lot of that is tied to you all and the relationship we have with you. So we thank you. I hope that as we continue to come through COVID, I can get out and see you guys at your stations. That's something that I'd like to do as well. And I've talked to Holly and the team about that, and we know that we've obviously had these limitations with COVID, but hopefully as we continue to come through that, I look forward to if you guys will have us coming out and visiting you at the stations and seeing how we can become a better partner for you. So with that, I would really just say thank you and welcome to St. Mark's. We're glad that you're here with us today. Okay, thanks.
Thanks, Jeremy.
Thanks, guys.
Thank you.
All right, I'm Carly. I'm the trauma program director, so I work super close with everybody here, but Dr. Mitchell especially. So today we just wanted to go through some of really the best cases that we saw in 2020, what's happened and what we're kind of looking forward to from a trauma team standpoint. Obviously, we de-identified everything, but just know that if you do recognize anything, any cases or anything, it's all confidential here. So a couple things that happened in 2020. So our Trauma 1 volume, which is our highest level activations, that volume doubled in 2020 from the year before, which had doubled in volume from the year before that. So we were able to see a lot more injured patients, and almost all of those Trauma 1s actually came from you guys, really from 101 a lot. We got a lot from 101, but came from you guys. Most of them were EMS arrivals, which is awesome. Overall, our EMS volume just for trauma increased by 16%. So despite the pandemic, we still saw really substantial growth from you guys. And then our injury severity increased. So that's just, the number of injuries our patients are getting and how severe each injury is. That increased year over year. And really that is completely in thanks to you guys and your trust that you have in us. And we are working really, really hard to continue that and continue our partnership with you guys. Do you want to talk about calling traumas from the field, from your standpoint?
Just go into the case.
Yep.
Well, thanks, guys. Nice to see you guys again. I see you guys quite a bit when you bring us patients. There's a few things besides jumping into this that I wanted to also expand upon. So Jeremy talked about the tower project, but additionally, we discussed the other projects in the back, maybe?
Yeah, so,
this is more in line with answering what you guys' requests are.
yeah, one of the things that we had heard from you all, and let me back up, a couple weeks ago we had our national group leadership here visiting us, and so as we toured around and showed them the place, we talked about the need to make some changes in that back entrance of the ED and with the canopy. We had heard feedback from you all that we needed to make some changes and address that, and so the great thing was our leadership above us saw that, recognized that need as well, and so we're working with them right now on plans to do that and make some changes. So we've got some drawings and different things that we're reviewing with the emergency department team and Dr. Mitchell, but we look forward to getting that project done as well to hopefully make that better for you all in terms of bringing those patients to us there and there in the back.
Yeah. The whole point of it is to make those a drive-through bays, which you guys have always said to me that back it in is kind of a pain and there's only 2 bays there. So the new plans will show 3 lanes, hopefully, that you guys could just pull through, drop your patient off, and keep on going. That's the plan, is to really extend that out. And so you guys brought that to us, so I just wanted to reiterate, when you guys bring us things, I'm happy to do whatever I can to make changes and take it to wherever we need to, because the goal here is to have the best partnership with you guys. Additionally, going on top of what Carly said about our volumes here, I just always like to reiterate the differences between a level 2 center and a level 1 center. And the American College of Surgeons, who governs the body of trauma across the country, they have tried really hard to make those 2 centers equal. So what I'm trying to say is that we can take anything that IMC can take. There's absolutely nothing that you could go there with that you couldn't come here with. The U has a couple specialties that we don't have, which is burn and teeth, but IMC doesn't have those either. So any level 1 trauma center in the Valley could see the exact same patients that we see. In fact, some of the times we share some of the specialist doctors. So I always want to reiterate, there's nothing that you can't bring us that you could take over to IMC. Does that make sense? And the American College of Surgeons has done a really good job of making those 2 systems equal, level 1s versus level 2s. And the reason there's a difference is because level 1s will train residents, which we won't do here at this given moment, and do research. They have research requirements and they have to teach. So that's the difference between the level 1s and level 2s. So when your colleagues get these 6 level 1s, if you're looking for a place to take them, we are happy to take them, and we have the capability of taking care of those patients. The additional thing that we've added last year, 2020, is we want to get you guys more involved with our trauma system. And so across the Valley, it's been not really encouraged for you guys to call traumas in the field, is that correct? Where like if you call it you don't say I got a level 1 or I have a level 2 trauma. You just kind of call and tell them what you have, and then they make the determination. Everywhere else in the country that I've worked, EMS makes all the calls. And so we wanted to bring that kind of here, and so we've asked if you guys wanted to start doing it, so we've allowed you guys to start calling the level of trauma in the field, and it's gone very well. We've had no issues with it whatsoever. A way to look at it is, if there's a mechanism, a traumatic mechanism that you're worried about, it's a trauma 2, and then if the patient has changed in vital signs, it's a trauma 1. So once they reach the point where their vital signs are already affected, that's kind of the determining factor of a level 1 trauma. The only mechanism that goes with level 1 is a gunshot to the torso or head. Okay, that's the only mechanism that counts effectively as a level 1. Okay, everything else on a level 1 is vital signs only. Okay, and then I know I keep saying level 1, level 2 centers, level 1, level 2 trauma. It's confusing, but any center can take any level of trauma, if that makes sense. So trauma 1s do not have to go to a trauma 1 center. Does that make sense? You guys get that? So it's just the way we designate how sick they are. So coming in 2021, some of the areas that we are going to be hitting hard here at our facility and encouraging is the C-collars, wearing C-collars in the field as well as C-collars in the hospital. We're seeing a lot of C-spine injuries where we end up sending them to CT, low mechanism of injury such as ground level fall, and they have C-spine injuries, even without pain. We've seen several of these come across our peer review that we review each month, where we send them over to the CAT scanner with a very low index of suspicion, and they have C-spine injuries. Because as you know, our patient population is very old here, and they break bones when they fall, even from a ground level fall. Additionally, there's going to be some new ACS trauma guidelines. There's the new book coming out not yet.
It should be this month.
This month.
We're just waiting.
So several years, the American College of Surgeons puts out the Trauma Bible, essentially is what it is. It's a different colored book each year, and they just go based on orange book or green, whatever the color is. This year, I think they're getting away from that.
Yeah, this year it's charcoal and red, but they're just calling it the 2020 update.
But
It'll go by years now.
But prior to this year, it's always been the orange book, the red, it's always the color of the book. But they're trying to get away from that, I think, and that book will come out in the next month, and they always update it throughout the 2 or 3 years that book will be in service, but there will be a lot of guideline changes based on current data. And so we'll get that out to you as soon as we see it, if it deals with pre-hospital stuff. Hospital construction, Jeremy spoke about. So any questions about any of that?
Yeah, sorry, does that reflect, so we're still using Nexus protocols, right? Will that reflect in Nexus, or do those things talk to each other, or?
No, so Nexus, yes, that's the way you guys are gonna use to determine whether or not you play, Nexus is really designed to determine whether or not they need a CT scan. That's the whole point of what Nexus was originally designed for. It's kind of
another thing, we don't use what it was designed to.
Yes. So just to kind of, you're right, that's what is taught, is that you guys follow the protocol. So essentially, if we're going to send someone for a CT scan, they should have a collar on. So that's why they teach EMS, well, if they meet that criteria, then they should have a C-collar. So if we're going to send them to a CT, you guys should put a collar on. We'll kind of expand this to explain what we're finding on our patient population. So what we do every 6 to 12 months, Carly goes through all of our patient data, like every case, and determines if we miss injuries or if we are finding more injuries than what we should be. And so we want to make sure our over and under triage rates are correct. And so what we find is that we're missing some of these injuries up front, so we have to alter our indications for ordering stuff. And we do that so that we're spot on our triage criteria, if that makes sense. And we do it based on our patient population here. So down in Florida or in the Midwest, they have different sets of rules, and the reason why is because in Florida you don't have the ski accidents. You know, in the Midwest and here we have a bunch of farm accidents. So we add what is appropriate to our patient population, and most of the patients we see here are elderly, and that's why we're finding some of this stuff out, if that makes sense. Any other questions? But we do it in real time, so we're not just doing it for no reason. We do it based on data and what we're seeing at our facility. So if there's no other further questions.
I just wanted to add one thing. So, like, one thing that Carly made real simple, even for our nurses here in calling traumas, is that if you think that they are going to emergently need an x-ray of some sort, that is like when you know that if they can wait a half an hour, however long the ER is going to have them wait to get an x-ray to find out that they have like a broken hip or whatever the situation is, then you don't necessarily need to call a trauma. But if you feel like it's emergent enough that you want them to have that imaging fast, that's the difference between calling a trauma and not calling it. So if you want to be able to get the hands on board and the resources, and it's kind of just like making your gut drop and you're like, yeah, something's not right, that's when you're like, oh, this is a trauma too, and we're not going to fault you. Because we trust your gut instinct, because you guys get to be around it all day long and see it, and you guys know, you just know, generally speaking. So, yeah, that's all.
And I want to make sure that it's clear that if you guys see anything when you bring a patient that makes you uneasy, the care you see, what's going on in our trauma bays, your interactions with our ER docs or our nurses, please tell me. Holly, you can get a hold of Holly, you can get a hold of me, she'll give you my cell phone. I'll speak to any of you at any hour of the day. I want to make sure that we can fix whatever you're seeing. If there's problems, I want to earn your trust, and I want you to realize that we are here to take care of the patients with you, and we want to do this as seamless as possible and make sure that you trust us with the really, really sick patients. And so that's what we're really wanting to beef up on. We're happy to take all the ones that you guys have been bringing us, but I'm really looking forward to gunshots again and bad car crashes. So, case reviews. So Carly put together a very nice, was it you or all of you three? All of you guys put together a really nice set of cases that we took care of, which can kind of show what specialties that we do have here and what kind of cases we can take care of here. So the first case, or the first set of x-rays are just various different injuries that we've seen here at St. Mark's. So stab wound to the liver. This didn't really project all that well, but what you'll see here is there's actually an injury here that could show, this is a little darker, there's a little blood there. And so there's a stab wound of the liver itself. This is the bladder. It's full of blood. It's hard for you to see that, but this won't project.
I'm trying to do it for you. It will.
Okay.
The new TVs don't let the green light.
Okay, well, they need to come up with a new.
I know.
So that was a skiing injury that he got. He actually injured his kidney and bled into his bladder and ended up with a huge clot, and that's what you're seeing on that image. Over on the far right upper area, there's another injury to the liver. Here you've got ruptured spleen. The spleen should be uniform, looking like that, and you can tell that it's not. There's blood around it. Same thing on the next one, and again, the same way with the lac. Okay.
Be safe, guys.
Yep. Yep, thanks, guys. Next one is pelvic injuries that we can take care of here. There's really no pelvic fracture or injury that we can't handle here. In fact, the guys that do our really severe traumatic pelvic cases come from IMC. So Dr. Hawes, who actually runs IMC's trauma ortho department, operates at our facility too, and he takes care of all these patients here as well. So what you see here is a bad motorcycle crash that destroyed his acetabulum and pelvis that needed to be reconstructed. There was a ground level fall with similar type of injury, just a little bit higher up on the iliac bone. We take care of chest injuries as well. We've got clavicle fractures, we've got flail segments, and multiple rib fractures. Anything that's in the chest we can take care of as well. Obviously, our orthopedic department, all of them can take care of all of our lower and upper extremities. We've got bad tib-pit fractures that we see across the board. We have tibial plateau fractures that our guys will take care of. And there's really nothing from an extremity standpoint, with the exception of a clean amputation that I would say needs microvascular. But besides that, there's nothing that our guys can't handle. We have vascular here, so if any of these have injuries to, say, the popliteal artery here, we've had a couple of those where we've called in our vascular folks. They'll go in with the orthopedic docs, and they'll fix the vessel at the same time that ortho will reconstruct the bones. Upper extremity, we have hand call 24/7, so there's no hand injury that we can't take care of. Here's a simple one with just fractures across there, partial amputation. That's nothing really bad. That is sticking your hand out of the window of a moving car. That's not very intelligent, but that's what happens to it, and so our guys can take care of that as well.
What did you hit?
Another car.
Oh.
Yeah, his hand was outside the window.
Really?
Yeah, so that's the post-op on the bottom right. That's his post-op imaging from.
Yeah. So that's what he ended up with.
Did he put his fingers back together?
He's not good at parallel parking.
I am, he was put his fingers back together, I'm just saying. Just kidding.
Well, we wanted to keep his ring, so we had to keep his ring for payment, so it was joke. All right, head injury, we get a ton of this here. We've got several neurosurgeons. We now have opened up our comprehensive stroke side of things, where we have neurosurgeons from IMC. One of them, Dr. Yoon, comes over here to do a lot of our interventional neuroradiology stuff. So besides that, we do all the head injuries with ground level falls, epidurals, subdurals, interparenchymals, and subarachnoids. There's really nothing from a head injury standpoint that we can't take care of here as well. Our neurosurgeons are very responsive, very up to date on the literature. They don't push back. They're very easy to work with. Cases. So first case we'll present is a 74-year-old who had a self-inflicted gunshot wound to his left, kind of chest wall, mostly in his arm. Crew was dispatched at 1 o'clock. They got en route within a minute. We're on scene within 4 minutes of that, and then at the patient within 2 minutes of that, after I believe the police department had to enter first. You guys were en route to us within 10 minutes after that, and arrival shortly after. So total time from dispatch to us is about 21 minutes, which is great. Vital signs at the facility or at the site was a little tachycardic, but everything was okay with him. So here this shows your guys' narrative to us. So it was dispatched, Unified Police made it entry at the location first. He was in the basement, laying on his side. He was alert, breathing without difficulty. Patient's clothing was removed on scene. Patient had admitted at the time that he shot himself. This was his third attempt at suicide. He had an exit wound in the back here with the entrance wound in front. There was about 200 to 300 cc's of blood on scene. Had multiple layers of clothes that were soaked in blood. His left arm appeared to be dislocated as well, or it was just massively disfigured from the fractures. No other injuries, no difficulty breathing, lungs were fine. He was able to control his airway. You guys controlled the bleeding with pressure and brought him to us at that point. He did confirm to you guys en route that he was also it was self-inflicted. When he came here, he became,
I don't know why it's not leaving.
okay, that's okay.
Oh,
There you go.
there we go.
All right, so patient became mildly hypotensive in the trauma bay. So when the patient arrives, if this is a level 1 trauma, it's myself or Emma, the other trauma surgeon, will be in the trauma bay meeting you guys, as long as it's called ahead of time so that I can get down there to meet you guys. And if it's a level 2, the ER doc will be in the room. We'll run through the primary survey. We'll allow you guys to give whatever time you need to give us the report. And if it's not happening that way, I need to know, because you guys need your time to be able to give us the report, so that, and have everybody in the room quiet so that we can know exactly what happened. This guy arrived, he was a little hypotensive, so he was given 2 units of blood based on what EMS had stated, that there was 300 cc's of blood at the scene, plus what you see as an injury, so likely they're hypovolemic, so we went ahead and started blood. At that point, we go through the secondary survey, do fast scan if it's indicated, chest x-ray, pelvic x-ray, and then the guy goes over to CT. He got a CT angio of his left upper extremity, which demonstrated the gunshot wounds, which I'll show you here in a second, but a severely comminuted proximal left humerus fracture, no injury to the vessels. There was no, I don't know if I call it macrovascular injury, so the big vessels, so all the major vessels were okay. Ortho was called, and patient in the CT scanner, it was decided the patient needed to go to the operating room. We called ortho met us there, and the team was in the operating room at that point. So that's the injury. As you can see, severely comminuted, bone fragments, or bullet fragments. You can see the soft tissue damage that was done there. Pretty destroyed if you get the different angles of it. So it was an open, displaced, comminuted left proximal humerus fracture from a gunshot wound. Patient gets his antibiotics and goes straight to the operating room. While in the operating room, ortho's there. Like I said, we do have vascular surgery colleagues that can come in if one of these vessels were injured. If it's injured into the chest, we'll go fix it, or we'll have the CT surgeons around to help us as well. So we have all those guys. So this was reconstructed with plates and a ton of screws, as you can see. This took a ton of metal to get this humerus back together. Wound was closed, and the humerus went back together. Pain was well controlled. At that point, first day post-op, he's already ready for crisis evaluation. He's stable. There's nothing else that needs to happen. And by the next day, he was admitted to the geriatric psych unit. Already, everything was taken care of. So just kind of showing that our orthopedic department is very responsive. They're willing to come in at a drop of a hat and help us, take us right to the operating room if necessary. Any question about that case?
The great thing with that is if it's called ahead of time as a trauma 1, the OR is already getting ready before you guys come. So that's why we were able to go to the OR from the CT scanner, is because we called it ahead of time, so they already had a room cleared, ready for patients.
And the blood is in the room.
Yep.
So as a level 1 trauma that comes through the door, if you call it ahead of time, there's already 4 units of packed red blood cells sitting there waiting on the patient. And so an FFP is beginning to be thawed. So it worked great in this case. The blood was in the room. We were able to just give it, get the patient stable, go straight to the operating room. Next case, 41-year-old female, rollover MVC. Crew was dispatched at 3 p.m. Again, you guys are really quick when you guys are dispatched. Looks like it takes about a minute for you guys to get out of the building. A couple minutes later, you're on scene with the patient a minute later, and then en route. Was that an hour? Is this the one that, oh, this is the prolonged execute?
Yeah, this was a prolonged. Yep.
Okay.
This was a mass casualty incident.
Well, it took us an hour to get them cut out.
Yep.
Yeah, the description is quite impressive. And then the patient arrived to us a little over an hour later Vitals on scene, a little tacky, but otherwise been a little confused, but otherwise stable. So this is your guys' narrative for us. Dispatch to the scene, the mass casualty, multiple vehicle rollover. There was, you guys, the ones that brought us this patient was assigned to the SUV that was upside down, restrained, trapped driver. One of you guys were able to, guys or gals, I don't know which one it was, we blanked that out, made entrance into the back seats of the vehicle behind the patient and was able to comfort the patient, reassure the patient, and they were complaining of leg and wrist pain. Was alert and oriented at that time, hanging upside down the entire time that it took to cut her out. She was restrained by the seatbelt, the dashboard had trapped both legs, and the roof was kind of enveloped over the patient's head. There was some bleeding coming from the patient's nose, but you guys were there to comfort her the entire time of the extrication. Took about an hour to get her out. Patient was then placed in C-spine precautions. The wrist was immobilized, and patient was then eventually transferred to us, and she became a little bit more confused en route. So again, I don't have the initial workup in the ED, but again, it'll be a primary survey, secondary survey. If they need to be intubated, we can intubate them immediately. We have capabilities of doing oral, nasal, or surgical airways if we have to. In a case where there's a lot of facial damage, we may not be able to get the oral intubation, but it's, we have all the equipment that we need in the ER to proceed on with surgical airways if we need to. In fact, our team is the team they call with any of these difficult airways. So whenever they have angioedema or they don't think they're going to be able to get intubation, they call me to go down and put a trach in. So we're used to being the kind of the difficult airway team. This one went over to CT after the primary and secondary surveys and had a ton of facial fractures, maxillary sinus fractures, orbital floor fracture, and there was a Lefort fracture on the head. There was subarachnoid hemorrhage. There's just a few little dots it doesn't show up as well here, but on the screen of the computer, you'll be able to see there's a little bit of dots of subarachnoid hemorrhage, which shows us that her brain was jarred a little bit. But it was very subtle on the medial aspect of the left parietal lobe, and then there was multiple facial fractures. She had this comminuted intra-articular fracture, the distal radius and ulna. So the ulna styloid was fractured, and then the main fracture here was the distal radius was fractured. So the injuries of this patient, so she had the facial fractures, the Lefort type fractures. These are the fractures that the face is completely separated from the skull. So there's 3 levels of that, 1, 2, and 3. And if you grab right inside the upper part of the mouth, you can actually move the maxilla. On a Lefort 1, on a Lefort 2 and 3, you can actually, the entire midface becomes detached from the actual skull itself. It's pretty impressive when you're able to move it, the whole face will move and the skull stays still. Yeah, it's a really complex fracture. Almost all of those will require some sort of fixation. We have facial plastics on 24/7 that can fix those. The orbital floor was fractured here, nasal bones. They had dental fractures and the head injury and the wrist, so multi-system injury here. The Lefort 1 fracture with the left orbital floor, lip laceration that was through the vermilion border. OFS, or our facial plastics group, was there. They actually said, let's just go to the OR right from the ED, along with Dr. Curtis, who's our hand surgeon that was on. Him and his son take a hand call for us. There are 2 of them at least. He was contacted, and he actually went to the OR with plastics. They did it together.
It's just, we'll be right back.
All right.
And there were 2.
And then there were 2.
You guys have to remember everything. We save the best till last.
Neurosurgery was consulted, and the plan with that subrector, usually we just keep them off blood thinners, repeat the head CT the next day, follow the neuro exams, which this patient did fine from the neuro standpoint, and our disposition plan at the time was likely home. So we went to the operating room with both plastic surgery in our orthopedic department. They fixed the Lefort type 1 fracture, and they plan to come back and do the orbital floor later. The orbital floor is kind of important that the swelling has to go out before they'll go fix it, because you want to make sure the face looks symmetric, and they want to use the other side to make sure that they can put those bones back together appropriately, or else the face will be asymmetric at the end. Orthopedics went in and did a irrigation and debridement of that open fracture and put that back together. Patient went to the OR that first day. Second day, repeat head CT was stable, so we did start him on DVT prophylaxis. And then the following day, there was a plan for them to return for the orbital floor fracture and nasal bone fractures. And then the patient was discharged on hospital day 4 with the family, with follow-up with plastics and ortho. Any questions on that case? Anybody online?
If you have any questions, you can star 6 to unmute, or you can chat them.
Okay. Case 3, 31-year-old male in BC. This patient came from one of our sister facilities, who is up in Ogden. This came from Ogden Regional, with a very complex pelvic fracture. This case is very complex. This took a lot of different specialties to actually take care of this patient. He presented to the Ogden after an MVC. Patient was a passenger in an MVC where the car was T-boned. The patient was stable when they got to Ogden emergency room. Workup demonstrated a comminuted fracture of the right iliac wing, extending inferiorly into the acetabulum, as well as bilateral inferior pubic rami. So his pelvis was kind of crushed. He coded in their ER from bleeding. They were able to get ROSC. MTP up there was initiated, which is the massive transfusion protocol, which if they think they're going to need to give more than 10 units of blood, people will activate the MTP. Bilateral internal iliac arteries were embolized by IR. This is up there. Was also found to have a transection of the urethra. And so at the time, they put a suprapubic catheter in. Hospital day 1, after that, they continued to receive blood products for pressure support, required pressors as well, additional angiography by IR, and a repeat CT showed no further active bleeding, and the patient had received 15 units of blood, 9 of FFP, 4 platelets, and 2 of cryo. That was all outside before we got the patient. They were then transferred to us for definitive care for our orthopedics department and for urology.
Was he transported by ground or air to you?
Ground. Ground, yes. We could do either way, but we're finding that you guys are just as quick as our helicopters are. So, from seeing at least. Maybe this would have been a little quicker the other way, but he was stable at this point, and he was coming to us for definitive care. You'll see here, acetabulum is this here, which is broken. The iliac wing is fractured as well. Again, acetabulum is broken. Inferior pubic rami, I believe, is broken as well. This is the suprapubic catheter that is in his bladder. Head CT. So the patient arrives at our facility, and sometime he's not completely with it. He's got altered mental status when he gets to us, and he's just not what they billed to us. So eventually we repeated a head CT, which shows this hypodensity here, and it turns out the patient stroked, and he's a young guy. And so what we find on his imaging is he's got the pelvic fractures, he was in hemorrhagic shock, and had a urethral transection, which I'll show you pictures of here in a second, and on top of that, he has an ischemic stroke. This is placement of the IVC filter, where they go up with their catheters and they drop the filter in place. These are all retrievable, they can be removed. They're there to prevent blood clots going from the groin up into the lungs, and in this case, from the groin to the brain, which doesn't make sense, because from the venous side, it'll go to the heart, and then the heart is filtered by the lungs, so you won't hit the brain unless there's a hole in his heart. So because of the ischemic stroke, and because he had the clots down in his veins, we were able to identify he had a hole in his heart, a PFO, and we called cardiology and was able to identify the PFO, and that was actually closed while he was here. This is the urethral injury. It's best seen right here. Urethra coming up. This is where the prostate goes up in the bladder. This is your extravasation. So those end up with a suprapubic catheter until that area kind of calms down and all the swelling, all the other injuries are taken care of, and then they'll go. And then there was one, all within an hour.
We should have all went with each of them and did a ride-along.
Yes.
Well, you could have.
So this patient ends up with the pelvic binder that was removed once he got here. He remained intubated, hemodynamically stable in our ICU. He had the IVC filter. He also had the DVT that was found. The patient had the right side weakness. The CT of the head showed the stroke. It wasn't new because you could already see it on the head CT, because head CTs won't show strokes right away. It takes a little while for the brain to actually lose its blood flow at that point, so it shows up later. Patient was extubated on day 5, transferred out of the ICU, and then about a week later went for ORIF of the acetaminophen once everything else had kind of settled out. And then the following day, cardiology came in and went ahead and closed the PFO, the hole in his heart. And then we removed the IVC filter before he left, because we can anticoagulate at that point. And patient was working with PTOT and speech, and he was unfunded, but we were able to get in place. He actually was discharged home. We actually kept him until he was safe enough to go home. And he actually had a very good recovery from all this, was walking and talking, and mostly normal from a mental standpoint before he left. So just to show the different specialties that we have: cardiology, urology, trauma surgery, intensive care, neurology, ortho, and IR were all involved in this patient's care here. And I think this is our last case. I assume that means you're going to get called out.
No, I'm not.
We literally had a packed room, and now we're down to one. 76-year-old male found down with facial trauma. Crew was dispatched, and a minute later they were en route on scene. About 9 to 10 minutes later, at the patient. A couple minutes after that, en route to St. Mark's about 10 minutes later, and was here about 10 minutes after that. Vital signs: hypotensive, bradycardic, and low SATs, hypoxic, and very altered with a GCS of 9. Upon the dispatch lights and sirens to the sidewalk for a 76-year-old complaining of altered level of consciousness for 10 minutes. He was laying on his back on the sidewalk at a laceration above his left eye. He was had swelling and discoloration around the right eye, multiple abrasions on his hands and feet or knees, and EMS arrived. Patients were unresponsive, only grunting. According to bystanders, he was alert and stated that he had fallen while walking. No one actually witnessed this. A C-collar was placed, backboard, and he was transported to us. Upon arrival to us, you could see on the monitor, actually in the trauma bay, it did not look appropriate to me, and so we got an EKG before we moved him at all, and it was clear he was having a heart attack at the same time. So presumably he had an MI, fell, or he fell, and the trauma caused an MI. But regardless, he now has possible head injury along with an MI, which is complicated in the sense that for MIs, a lot of times they need anticoagulation, and if you take them to the cath lab to fix this, and he's got a head bleed, then you're in a lot of trouble. So we do priorities at this point. We called cardiology and said we're having a STEMI at the time, and we took him over to CT to rule out an acute hemorrhage first to make sure that the head was clean before cardiology would take him off to the cath lab. The cardiologist joined me in the CT scanner at the time. We were able to identify a nasal bone fracture, but the patient went straight from the CT scan to the cath lab per cardiology because they were waiting there until I cleared him from a head bleed standpoint. And then they took over at that point. He did require some pressors. He eventually was extubated. They worked on his heart, and then he was doing okay, but then began to have hypoxic levels, placed on BiPAP, and they were planning on fixing one of his valves, his aortic valve, and he declined too quickly for them to get him in there. So he had a bad heart. All this was related to his heart, not his trauma. So he had valvular disease as well as coronary disease. So our cardiologists and CT surgeons were on board and managing him at this point, but he eventually declined and passed away. And so cardiac arrest, the STEMI, and then the nasal bone fracture is what he ended up with. Any questions?
No, very well done.
Okay.
Do we have any questions online, you guys? You can star 6 to unmute.
One thing I wanted to say about that last case was I thought it was a really astute and great observation as quickly as the treatment team realized that that EKG was not looking appropriate on the monitor to kind of switch gears. I mean, I was in the room when it happened, and it was less than 1 minute, but between patient arriving and them identifying, oh, there's something wrong.
Yeah.
And I thought it was really awesome how the team just switched gears and handled the STEMI and the trauma at the same time so quickly.
Wasn't the outcome we wanted, but
No,
Right,
but
because that's still really hard, because we do that sometimes. We show up at a fire and there's somebody struggling with medical and we have to switch. So I know that's what you're talking about is really difficult,
yeah.
but required.
yes,
Yeah.
it is required.
Yeah.
Anything online?
Hello, Dr. Mitchell, miss you guys. That's from Chris Shields.
Hi, Chris. We miss you too.
All right, you guys, big, huge thank you to our trauma team, to Jeremy, who stopped by, our CEO, and to 101 and 104 for as long as they lasted at Sam Georgian State the whole time, and just make sure that they get all the training. So for those of you online, if you can make sure you text me 801-755-3317, your name, and if you're attending as an entire station, can you send me all the names of those that are working? And then just to let you know, we did record this. We will send it out. And then what's really exciting is all of our EMS education that we've done for our entire division, we now have onto a YouTube channel with a link from our website. So you will be able to access any training that we've done here at St. Mark's, also at Lone Peak, throughout the whole entire valley, and then you'll also get Alaska and Idaho's EMS education also. So really excited about that. We'll have some posters up in your break rooms to let you know with the QR code so you have easy access to it. And so that you'll see that coming out. That just went live Friday. So we're really excited about it.
And if there's anything you guys want us to talk on, any specific topics, we're happy to put something together.
Yeah, so we talked about doing that. If I can put it up on LMS and actually share it with everybody that's target solution.
Okay.
So the other departments can actually get it and also the certificate that we built. So they can upload that to National Registry and get those hours.
Perfect. And if there's anything you guys come up with, if you see a case and like, oh, it'd be nice to know a little bit more about that from the doctors or the hospital side, we're happy to put something together.
Yeah, we have 2 or 3 hospital reviews a week now with you.
Perfect. Perfect.
Awesome.
All right, thanks for joining us online, and take care. Everybody have a safe day.
Stay safe.
Thanks, you guys. Hi, Dr. Mitchell.
Hi.
Hi,
I miss you
Chris.
guys.